Hello everyone and welcome back to my playlist of pharmacology. मिनी कैटजिंग से हम चैप्टर नंबर 48 आज करेंगे which is about anti-fungal agents. हम antibiotics की सीरीज कर रहे हैं and we have talked about various antibacterials. Then we talked about tuberculosis drugs. And today we are going to talk about antifungals, which is actually, it's sometimes a nightmare to treat fungal infections. They are sometimes very difficult to treat, particularly in immunocompromised patients or those who have low neutrophil counts, neutropenic patients. Most fungi are resistant to conventional antimicrobial agents and relatively fewer drugs are available for the treatment of systemic fungal disease. So systemic fungal disease agar hai, if God forbid any organs are involved or say for example areas like your nails are involved, that's a difficult thing to treat. M4B, amphotericin B, the azoles, जिसके अंदर बहुत सारी drugs हैं such as fluconazole, itraconazole, ketoconazole, voriconazole, and echinocandins. These are the primary drugs used in systemic infections. They are selectively toxic to fungi because they interact or inhibit with the synthesis of something which is only present in fungi, not humans. Ergosterol, it's a sterol unique to fungal cell membrane. So, अगर आप broadly classify करें, जैसे mini कैटजिंग में हमेशा करते हैं, so the drugs which act on fungi are broadly divided into those which disrupt the microtubules, such as grysofulmin. They may block nucleic acid synthesis, such as flucytosine, beta-glucan synthesis, such as echinocandins, or alter the cell membrane permeability, such as all these, the azoles and the terpenophenes and the polyenes. So, ये तमाम categories हैं जो available हैं for usage against fungal infections. Let's see what are the drugs which are used particularly for systemic fungal infections. Topical is different. Topical fungal treatment, ointments and everything. Now here we are discussing what do we use in systemic stuff, okay? So M4B, पूरा नाम इसका एम्फोटेरिसिन बी है, बाय द वे. मैं इसको प्यार से M4B कहता हूँ. आप भी प्यार से M4B कह सकते हैं इसको, okay? M4B continues to be an important drug for the treatment of systemic fungal infections. However, several azoles and echinocandins are proving to be just as effective as amphotericin B, and cherry on the top that they are less toxic. Now, classification and pharmacokinetics of amphotericin B, it is a polyene antibiotic related to nystatin. Amphotericin is poorly absorbed from GI tract and is usually administered IV. Okay, that's an important point to remember, drug administration. As a non-lipid colloidal suspension, as a lipid complex, or in so there are different formulations available. The drug is widely distributed to all tissues except the CNS. So its entry into the CNS is not very well. Elimination is mainly via the hepatic metabolism. Half-life is approximately 2 weeks. This is all that you have to remember. A small fraction of the drug is excreted in the urine. Dosage modification is necessary only in extreme renal dysfunction. So if somebody is having moderate kidney problems, that is still okay to give amphotericin B, but this is not dialysable. So if somebody is on dialysis, the drug is going to stay in the body. Okay. Now, how does it work? It's fungicidal action of amphotericin B is due to its effect on the permeability and transport of fungal membranes. Polyenes are molecules with both hydrophilic and lipophilic characteristics. They bind to this cholesterol variant, which is present in fungal membrane called ergosterol. It's a sterol which is specific to fungal cell membrane, and resistant, which is not very common, I would say, can occur via decreased level of or a structural change in the membrane. So the drug has to target ergosterol, and if ergosterol changes its shape or function or whatever, if the configuration of the target changes, then the missile is not going to work. Okay, when is it used clinically? Is one of the most important drug available for systemic mycosis, and is often used for initial induction of regimes before follow-up treatment with an azole. So that is pretty heavily used, and perhaps one of the very limited options available for systemic treatment of fungal infections. It has the widest antifungal spectrum of any agent and remains the drug of choice or co-drug of choice for most systemic infections caused by Aspergillus, blastomyces. So that's the range against which this is very effective. Ampho-B is usually given by slow IV infusion. ये मैंने start में आपको बताया कि this is effective IV. It's not absorbed from GI tract. Okay. So dangerous has been used intrathecal administration because अगर आप IV देंगे तो it is not going to reach the brain. So people have tried it intrathecally, but I mean, I think it's no more routinely practiced because इसके associated complications बहुत हैं, procedural complications बहुत हैं. Local administration of the drug with minimal toxicity has been used in treatment of mycotic corneal ulcers and keratitis. So topical application, right? Now, इसका toxicity profile. Infusion related adverse effect related to IV infusion commonly include fever, chill, muscle spasms, and shock like fall in the blood pressure. So when you start the drip, you must monitor these side effects because they come pretty quickly, okay, and you have to report them. Some of them can be very, very serious. These effects may be attenuated by a slow infusion rate and pre-medication with antihistamines, antipyretics, मेपेरिडीन और ग्लूकोकॉर्टिकॉइड. ये पहले से दे दें ताकि जो एक्सपेक्टेड साइड इफेक्ट्स हैं वो किक ही ना कर सकें. Amphotericin B decreases the glomerular filtration rate and causes renal tubular acidosis with magnesium and potassium wasting. So remember all these things, okay? Hypokalemia can be a finding because of the treatment of this particular drug. Anemia may result from decrease in the renal formation of erythropoietin. So all these things you have to bear in mind. Although concomitant saline infusion may reduce the renal damage, the nephrotoxic effects of the drug are dose limiting. So the more the dose, the more the effects. And one tip is, so actually अगर आप नोट करें तो एम्फोटेरिसिन बी को देने के लिए बहुत सारी एहतियात की ज़रूरत है. आप पहले से ये दें, एंटीहिस्टामिन्स दें पेशेंट को, एंटीपायरेटिक्स दें, पेशेंट को ड्रिप लगाने के बाद मॉनिटर करें इन तमाम इफ़ेक्ट्स के लिए, और पेशेंट्स को आप साथ में सलाइन लगाएं. So there's a lot of preparation if you are giving amphotericin B IV to somebody. Okay, and you may have to think about dose reduction if possible in some infections when amphotericin B is used with flucytosine. Liposomal formulations of amphotericin B have reduced nephrotoxic effects, possibly because of decreased binding of the drug to the renal cells. So overall, it's not an easy drug to handle. You need a lot of preparation in order for this drug to be prescribed, okay? Neurotoxicity. Intrathecal administration of amphotericin B may cause seizures and neurological damage, but that also comes later. The first problem is the administration intrathecally, which is also not free from the side effects. So the first drug that we covered is amphotericin B, which is very useful in systemic infections. Here is a good diagram telling you which drug works which way. So this is the fungal cell membrane and cell wall. Amphotericin B is the first one, and it is working on ergosterol on the cell membrane. Okay, right जनाब. Next जो drug हमें discuss करनी है, that is flucytosine, 5-fluorocytosine. 5-fluorocytosine is a pyrimidine antimetabolite related to anti-cancer 5-fluorouracil. आपने ये नाम तो डेफिनेटली सुना हुआ है ना, 5-fluorouracil. ये उसका भाई बहन है, कज़न है, 5-fluorocytosine. It is effective orally, so that's something different from the previous drug, and is usually distributed to most of the body, including the CNS. So there are things different from the previous drug, okay? And the drug is eliminated intact in the urine, and dose must be reduced in patients who have kidney problems. How does it work? It is accumulated in fungal cells by action of membrane permease and converted to by cytosine deaminase to 5-fluorouracil, which is an inhibitor of the thymidylate synthase. Selective toxicity occurs because mammalian cells have very low level of permease and deaminase. So basically fungi are targeted and the rest of the cells are okay. Resistance can occur rapidly in flucytosine अगर अकेले इसको यूज कर रहे हैं. यूजुअली इसको यूज करते हैं एम्फोटेरिसिन बी के साथ या किसी और एजोल ड्रग के साथ. Okay, so that's pretty useful drug as well. The antifungal spectrum of 5-fluorocytosine is narrow. Its clinical use is limited to the treatment in combination with ampho or any azole, particularly to Cryptococcus neoformans, and that's all. और एक ही पर्टिकुलर कंडीशन में आप यूज कर रहे हैं, मे बी ऑल्सो कॉज बाय मोल्ड्स जो क्रोमोब्लास्टोमाइकोसिस इन्फेक्शंस, दैट्स ऑल्सो सिस्टेमिक इन्फेक्शन बट रूटीनली द क्रिप्टोकोकस नियोफॉर्मेंस। और इस कंडीशन में भी आप ये ड्रग अकेले यूज नहीं कर रहे, यू आर यूजिंग द ड्रग इन कॉम्बिनेशन with either amphotericin B or an azole drug. So you think about it, how useful the drug is. Prolonged high plasma level of flucytosine causes reversible bone marrow depression, alopecia, liver dysfunction. Okay, so if you look at this diagram, you should be able to find that this is working at the level of DNA RNA synthesis because it is ultimately affecting thymidylate synthase. Okay, the next group of antifungal drug we have to talk about is azole antifungals. The azoles are used for systemic mycosis, include ketoconazole, fluconazole, itraconazole. These are all different variants. Their oral bioavailability is variable. हर ड्रग की एक जैसी नहीं है. Fluconazole and posaconazole, izavuconazole and voriconazole are most reliably absorbed via the oral route compared to the others. Most triazoles are available in both oral as well as IV formulations. So you see the first drug that we talked about, amphotericin P, was IV. Then we talked about 5-fluorocytosine, that was oral. And now we have a group of drug which is both oral and IV available. The drugs are distributed to most body tissues, but with the exception of the fluconazole, drugs levels achieved in CNS are very, very low, which means fluconazole can actually go to CNS. Liver metabolism is responsible for elimination of ketoconazole, posaconazole, inducers of the drug metabolizing enzyme, which is rifampin, for example, decrease the bioavailability of the itra. So these drugs can actually interfere. So now here is the scenario. If you're taking rifampin for any reason, and if you are co-taking these drugs, azoles, you need to think about कि जो आप dose दे रहे हैं वो actually काम कर भी रहा है patients में या नहीं, because rifampin is there. Okay, fluconazole is eliminated by the kidneys, right? Usually unchanged. Mechanism of action: they work by interfering with the fungal cell membrane permeability by inhibiting the synthesis of aldosterol. The drug can act the step of 14-alpha demethylation of lanosterol. Not important to remember. Just remember it works with interfering the aldosterol. Okay, so azoles work by disturbing the conversion of lanosterol to aldosterol, and once this is not produced, then the cell membrane integrity is lost, and this is what is the antifungal action. Clinically, keto is usually ketoconazole, has a narrow antifungal spectrum and causes more adverse effect than other azoles. Ketoconazole is now rarely used. Okay, but it was one of the key drugs once, but now there are other derivatives, so this is not commonly used. However, it continues to be used for chronic mucocutaneous candidiasis and is also effective against dermatophytes. Fluconazole is a drug of choice in esophageal and oral candidiasis. Very important, particularly in HIV patients. A single oral dose usually eradicates the vaginal candidiasis. Fluconazole is the drug of choice for treatment and secondary prophylaxis against cryptococcal meningitis, and it's an alternative in Cryptococcus neoformans. Okay, the drug is equivalent to Ampho B in candidemia, but that's an important drug to be used. You see, esophageal candidiasis, also vaginal thrush. This is a drug which works pretty well. Then we have itraconazole. This azole is currently the drug of choice for systemic infection caused by blastomyces. And then we have voriconazole. It has a wider spectrum. It is a co-drug of choice, particularly in aspergillosis, which has been invasive. Some studies report greater efficacy if combined with amphotericin B. Voriconazole is an alternative drug in candidemia, which with activity against some fluconazole resistant organisms in AIDS patients. So the matter of the fact remains that you have to remember quite a lot of things कि कौन सा particular antifungal किस particular fungus के against active है. This is also a broad spectrum triazole, posaconazole. It has activity against most species of Candida and Aspergillus. Izavuconazole is a triazole with an antifungal spectrum which is roughly similar to posaconazole, which means it's pretty wide spectrum. Preliminary evidence suggests it is better tolerated than posaconazole. Now, all these drugs do not come without side effects. They do have their side effects. Adverse effects of the azoles include vomiting, diarrhea, rashes, sometimes also hepatotoxicity. Ketoconazole is a notorious inhibitor of P450 hepatic cytochrome isozyme and may increase the plasma levels of many others. So this basically helps metabolizing other drugs, and if this is inhibited, levels of other drugs go high. Very important. Okay. Now P450 की inhibition isoforms, ये particular isoform जो कि drug metabolism में involved है, it interferes with synthesis of adrenal and gonadal steroids, leading to increased levels of some of them, such as estrogen, leading to gynecomastia, menstrual irregularities, as well as infertility. The other azoles are more selective inhibitors of fungal cytochrome P450, although they are less likely than ketoconazole to cause endocrine dysfunction. Their inhibitory effects on the liver drug metabolism enzyme have resulted in drug interaction. So overall आपने ये याद रखना है कि many of the antifungals, particularly azoles, they interfere heavily with cytochrome P450 system, and therefore they have an impact on how the levels of other drugs are maintained in the body. Okay. Now, based on the animal studies, voriconazole is a class D drug for the pregnancy risk, but that's preclinical data only, okay? We do not know for sure if this is also happening in humans or not. Then the other group that we have is echinocandins. इनकी examples की अगर बात करें तो caspofungin, for example, the first novel class of antifungal agents, इस particular group का पहला drug आप समझ लें. Other echinocandins include anidulafungin and micafungin. They are used IV. The drugs distributes widely to the tissues and eliminated by the hepatic metabolism. Okay, right. Half lives दी हैं, याद रहती हैं तो कर लो, नहीं रहती तो it's okay. इनका mechanism of action important है. They have fungicidal action, inhibiting the synthesis of beta-glucan, which is also an important member of the cell wall of fungi. Clinically, they are used for disseminated and mucocutaneous candida infection in patients who fail to respond to amphotericin B. So that's kind of a reserved drug, okay? Toxicity profile, actually these drugs are well tolerated. Infusion related to effect of caspofungin include headache, GI disturbance, flushing because of histamine, fever and rash, but these are easily bearable or easily treatable by, say for example, giving Panadol for fever and simple antihistamine, and that should work. Micafungin also causes histamine release and elevates blood levels of immunosuppressant drugs such as cyclo. So these are some drug interactions to remember. Then a couple of more headings, systemic drugs for mucocutaneous fungal infections. So if your skin and the membranes, the mucous membranes are involved systematically, then what we do? Drugs used orally in the treatment of dermatophytes include griseofulvin, terbinafine, and several azole antifungals. So previously we talked about the systemic fungal infections. So some systems are involved, okay? Esophagus, for example, vagina, for example. Now we're talking about mucocutaneous infections. So griseofulvin, oral absorption of griseofulvin depends on the physical state of the drug. Ultra micro-sized formulations, which have finer crystals or particles, are more effectively absorbed. The drug is distributed to stratum corneum, where it binds to keratin. Biliary excretion is responsible. So because it reaches up to the level of the stratum corneum, it's a very good drug for treating cutaneous involvement, particularly nail infections. It interferes with microtubule functions in dermatophytes and may also inhibit synthesis of polymerization of nucleic acid synthesis, okay? It's fungistatic, it stops everything. Clinical uses, not active tropically, systemically देना पड़ता है आपको. Oral formulation of the drug is indicated for dermatophyte of the skin, hair, also nail infection included, but has been largely replaced by terbinafine and the azoles. Adverse effects are there, including headache, GI irritation, photosensitivity, liver problems. Griseofulvin should not be used in patients with porphyria because already livers are screwed in there. Griseofulvin decreases the bioavailability of warfarin. Therefore, drugs have to be adjusted. It also causes disulfiram-like reactions with ethanol. So, all very important if you are prescribing griseofulvin to somebody. Terbinafine and naftifin inhibit fungal enzymes, squalene epoxidase. This causes accumulation of toxic levels of squalene, which interferes with ergosterol synthesis. Again, cell wall में ultimately मसला, ठीक है? Terbinafine is available in both oral and topical forms. Like griseofulvin, terbinafine accumulates in keratin, but it is much more effective than griseofulvin in onychomycosis. So nails वगैरह अगर involved हैं. Adverse effects include GI upset और ये सब चीज़ें जो हमेशा होती हैं बहुत सारी drugs के साथ. Does not inhibit the cytochrome P. So इसके drug interactions नहीं है, ये अच्छी चीज़ है. Mucocutaneous infections में another option that we have is the azoles. Azoles other than voriconazole and posaconazole are commonly used orally for the treatment of dermatophytes. Pulse or intermittent dosing with itraconazole is as effective in onychomycosis as continuous dosing, but the drug persists in the nails for several months. Typically, treatment for 1 week is followed by 3 weeks without the drug. So that's what is the usual pulse dosages if you are treating mucocutaneous fungal infection with azoles. Advantage of pulse dosing include a lower incidence of adverse effects and major cost saving. Well, these are expensive drugs, obviously. Topical forms of various azoles are also available, but topicals with the thinking they will eradicate it completely is not a good idea. You have to give systemic as well. Systemic along with topical. So अगर किसी के nails में infection है, you give the systemic drug which reaches here by blood, and you also give topical ointment or the liquid drops. Now, topical antifungal therapy. A number of antifungal drugs has they are used topically for superficial infections such as caused by the Candida albicans or other dermatophytes. Nystatin is a polyene antibiotic that disrupts the fungal membrane by binding to ergosterol. Ergosterol is the mainstay of the fungal treatment because it is a very integral component of the cell wall of the fungi, and if you disturb ergosterol, you kill the fungus. Nystatin is commonly used topically to suppress local Candida infection and has been used orally to eradicate GI fungi in patients with impaired defense mechanism. Because अगर आप GI के लिए भी particularly अगर आप दे रहे हैं तो that can reach to the particular area जहाँ भी GI tract में infection है. But again, if GI involvement is there, I would recommend using a systemic drug rather than topical. Other topical antifungal agents that are widely used include azole compounds such as miconazole, clotrimazole. These are only for superficial infections. Okay, so that concludes our discussion on antifungal treatments. We'll start next another topic which is on antiviral agents. It's going to be super important because we'll be talking about the drugs which kill viruses. So all the very best. Stay tuned. My name is Dr. Asif Qureshi and you are watching Dr. Asif Lectures.